Hand it over to you.
Sure, great. Thank you, Mary. Can you hear me okay?
Mhm.
And I'm assuming you could see the slides then?
They are perfect.
I'm having trouble advancing them. Here we go, maybe. Okay, awesome. So today I'm really happy to be here. This is a privilege because I have loved this series all year long. I think the topics are fantastic and I'm fairly passionate about preventing or postponing dementia. So this is great. When this topic came up, talking about hypertension, hyperlipidemia, and diabetes, I thought, oh, yes, great. They kind of meld together, and this will be a great topic altogether. I had no idea how much information there is on this. So we are going to be taking an eagle's eye fly over this topic today. There's so much data and lots of studies, and as you'll see, it's exciting to see the data, and yet we know there is a lot more needed yet to come. So we're going to dive into this. You all are familiar with this little graphic, right, from the Lancet study that came out, the update in last year, looking at the various things that if we did all of these preventive areas of took care of all these areas of our health, we could prevent or postpone up to 45% potentially of all forms of dementia across the globe. So we're going to take these three as a triple threat to brain health today. And the learning objectives are pretty straightforward, but you'll see a pattern as we run through the next 15, 20 minutes. We're going to review the prevalence of these three risk factors for brain health. And I'm going to use some abbreviations because hypertension, I'm going to abbreviate as HTN, hyperlipidemia, HLD, and diabetes mellitus, specifically talking about more a focus on type 2 diabetes. We're going to try to understand the impact of these risk factors on brain health and really kind of talk about the timing and the mechanism of these risk factors. So why would these particular items affect our brain health? And then the million-dollar question, we're going to explore whether actually treating these diseases as they come up, can we treat them and prevent or alter the development of dementia, right? We certainly want to prevent getting them, but if we do get them, then the million-dollar question, does treating them actually help us with our brain health? So let's just look at these three factors. So hypertension in the Lancet study is described as accounting, if we could prevent it, we could prevent 2% of dementias. Hyperlipidemia was added on in 2024, the very latest data. It was somewhat controversial earlier on, and the data seems to now really be landing that lipids do make a difference, and a fairly high, significant proportion of dementia could be reduced, 7%, which rivals the hearing loss, if you'll notice, a very big bucket of prevention is hyperlipidemia. And then diabetes mellitus, 2%. Again, these are specifically identified as midlife risk factors. So if you look at this fun graphic, right, we're looking at midlife, not early or late life, but they could be risk factors in late life. We'll talk about that in a minute. But knowing this particular focuses on midlife. What do I mean by midlife? Before age 65, an average of 50 years of age. So somewhere in that, what we commonly think of as midlife. How common are these risk factors? Well, just in the US population alone, 48% of our population has high blood pressure. That's a lot. Over a third, 38%, have some form of hyperlipidemia, and 11% have diabetes mellitus. Generally, that's type 2 diabetes. Now, I was surprised, I don't know if any of you were surprised, that diabetes 11% sounded kind of low in my mind because we hear so much about diabetes and its risks, which are huge for cardiovascular health, neuropathy, eye health, kidney health, right? But part of this data, we have to think we're looking midlife, and the numbers might not seem familiar to someone like me that does geriatrics most of the time. For folks over the age of 65 years old, almost 30% have diabetes. So the risk of diabetes does increase as we get older. But for the purposes of these midlife dementia risk factors, we're looking at 11%. So I know we have not a huge crowd, but how many of you, how many do you think people have all three of these risk factors? So if we were to add them all together, I know we can't really see a show of hands, but if you want to unmute, give me a percent. What percent of people in the United States do you think have all three of these risk factors? Hypertension, hyperlipidemia, and diabetes, all taken together.
Well, I wouldn't be able to guess at a percentage, but my sense, just influenced by what I read day in and day out, is probably a pretty significant percentage.
Yeah, I'm thinking with you. Yes, I agree. Anyone else want to take a guess?
Just to let you know, Dr. McCurry, we're getting a guess of a 10% or an 8%.
Oh,
and
thank you.
my verifying question was going to be in midlife or any age?
In midlife, yeah. Well, it could be any age, actually, but statistically, we're looking towards midlife group, yes. So those are good guesses. 8, 10, any last guesses? Well, I was surprised because looking this up, when we take all them together, so of the US population, 48% have at least one, right? 13% have two, and only 3% have all three in midlife. So it's kind of interesting to consider that. It seemed low to me, and I'm still going to study that out because it seems low to me, but there you go. The importance of this is that in the brain health studies, the risks of cognitive decline appear to increase when we start clustering these risk factors. So it is important, if you have one or two, the risk of brain cognitive impairment tends to increase. So kind of interesting to keep that in mind as we look at these three different risk factors. So I'm going to take each one separately. We're going to kind of discuss how big is the risk factor, what's its impact, what might the mechanism be, and then treating that particular risk factor, if it develops, is that valuable to prevent or alter the course of cognitive dysfunction? So in hypertension, this is probably the most important risk factor. Why? Because clearly 48% of the United States population has hypertension. So by mere volume of people affected, it becomes one of the most important risk factors. Midlife hypertension increases all-cause dementias by a 1.5-fold increased relative risk to someone who doesn't have high blood pressure. And it might be greater for women than men. That's very preliminary data, but could be. I wanted to just touch on the definition of hypertension because it has changed since I first graduated med school till now. I won't tell you how long that's been, but the definition itself has changed, but so has the definition of air pollution and particles per million. So normal blood pressure is now below 120/80 or up to 120/80. We say that someone has elevated blood pressure if that systolic top number is 120 to 129. Wow. And stage 1 hypertension is that top systolic number 130 to 139, or the bottom number 80 to 89. And you have stage 2 hypertension if that blood pressure is greater than 140/90. Either top or bottom meets that criteria. So we've become stricter on our definition of hypertension. Maybe that's why we have so many people with hypertension in the United States, but the data really does play out that those higher blood pressure numbers do work out to greater cardiovascular disease, greater stroke risk, and now we know cognitive risks. So considering high blood pressure is critically important. How we measure blood pressure is also critically important, but we won't get into that because that would take another hour to describe. So the mechanism on brain health is very complex. We know for sure that hypertension increases the risk for stroke and therefore vascular dementia. But there also seems to be changes in the stiffness of the blood vessels. They're less pliable, and this tends to alter regional blood flow. The blood flow is diminished in areas where the blood vessels are stiffer. Also, there's a theory and some bench lab data looking at arterial stiffness being related to amyloid plaque buildup. And there's some observational data. This is actually quite interesting. A pattern of high blood pressure in midlife and then a drop in blood pressure 5 years before a dementia diagnosis. So it's kind of an interesting observational data that we've discovered. Hard to predict that dementia just from a blood pressure being high in midlife and then dropping. Don't want everyone to get worried, but there's an interesting pattern there that could relate to blood vessel stiffness as well in the brain. So what about treatment? Does treating high blood pressure prevent dementia? Well, you can imagine this is a very hard thing to study, right? There are numerous observational studies or meta-analysis where we're just looking at populations over time. We haven't done an intentional intervention with someone being treated and someone not being treated for high blood pressure, right? That would be somewhat unethical, and I don't think it would get by any review board to have an untreated hypertension group. So the observational studies we have to look at do show that long-term antihypertension medication started in midlife was mildly protective against cognitive impairment and dementia. So treating hypertension may be very valuable. We don't have a direct randomized controlled trial though, right? And we probably never will. So there have done studies on which blood pressure medicines might be most helpful, right? And there's no clear preferred medicine at this point. There was one trial that suggested that angiotensin II receptor blockers, these ARBs, these are things like losartan you might have heard of, they were more helpful at preventing cognitive change. Another study showed calcium channel blockers, things like amlodipine and verapamil, also had a lower dementia risk after taking those medicines, but clearly more study would be needed. So I think treating hypertension would be very valuable for sure. Not just for the brain, of course, but definitely. What about, sorry, I need to do something and I apparently touched a button I shouldn't have. Try to be able to forward the slide again. My slides are stuck. Here we go. How about that? So hyperlipidemia. This is a newly added risk factor, right? Like I said in the latest Lancet article, and has a 7% potential reduction on the risk of dementia if we can prevent this. The studies, however, are mixed. Part of the trouble is that many of the studies were done for other reasons than for looking at brain health, maybe cardiovascular risk or stroke risk. And the data was a secondary endpoint that they looked at in the study. So studies have been mixed results. But lately, it does seem that the LDL cholesterol, which is kind of our bad cholesterol, a high LDL cholesterol in midlife, again, before age 65, was found to be associated with a higher risk of developing cognitive impairment. And this included both vascular as well as Alzheimer's dementias. The small density LDL was a more specific target, seemed to be the riskier kind of LDL to have. So the greater the small density LDL, the greater the chance of cognitive impairment. There are other lipids under additional study. The ApoB48 is a type of lipid that might be protective. There was a small study looking at the HDL cholesterol, which is our good cholesterol, thought to be good for the heart in general. That also seemed to be protective against dementia, but the relationship is very complex. There was another study looking at the HDL particle size. So again, this density concept, the greater the density of the HDL, it might be a more protective kind of HDL, and the fluffier, less dense HDL may not be as good for us. Just last month, it's July 1st, so a week ago, Neurology Journal put out data from the large Framingham database, and that's definitely supported the small density LDL was not good for our cognitive health, but the HDL, those that had a low HDL in one of the quartiles also had a lower incidence of Alzheimer's disease. So yeah, that's opposite of what the other studies have said. So it looks like the particle size of the HDL may be important. I know that is very complicated, and I'm going to step deeper into the water of this whole HDL and statin ideas. The mechanism of the hyperlipidemia on the brain is not fully understood. Keep in mind that the LDL, the bad cholesterol, doesn't cross the blood-brain barrier unless the barrier is already damaged. So does it require some vascular disease first, and then we have a problem? We know that cholesterol in the brain does a lot of things. We need it, but we don't know what kind and at what ratio. It is thought that the cholesterol may enhance formation or buildup even of beta amyloid. It could affect cerebrovascular disease, obviously could affect local inflammation, or even tau metabolism may be affected. So all these proteins also involved with Alzheimer's disease may be affected by lipids, not just the vascular attack. And does treating hyperlipidemia prevent dementia? So this is truly a can of worms. Most of the studies focus on statins for treatment of hyperlipidemia. Recognize that doing population studies on diet alone and exercise alone are thwarted with difficulty. What someone considers a healthy diet and an amount of exercise is very hard to maintain and quantify over years of time. So dietary lifestyle studies in this preventing dementia with hyperlipidemia are difficult. So again, most of the data does look at medication treatments, and especially statins. Retrospective studies do show there's an association between the sustained use of a statin started in midlife and later reduced risk of dementia. So statins might be helpful for brain health in this retrospective studies. There are some prospective, looking forward observational studies that had mixed results. But again, these were not designed to measure cognitive health. They were mostly designed to look at stroke risk and heart disease risk. Using statins preventively, like if you have no high cholesterol and you just start taking a statin, there is no determined or demonstrated preventive role for statins. So just additionally, there's been a lot in the popular media about statins and dementia over the last 15, 20 years, longer than that. Back in the turn of the century, that sounds like a long time ago, they looked at any reports coming to the FDA of memory loss with people on statins from 97 to 2002. They found 60 reports, which if you consider how many people were taking statins, this is a minor amount, a teeny tiny number of reports. 14 of 25 of these individuals improved when the statin was stopped. 4 were challenged with the medicine again, and they did develop memory loss again when they restarted the medicine. And those symptoms were usually within 30 days of starting the statin, right? So based on a lot of the literature and putting together many different recommendations, most providers that prescribe statins today are looking at this. If someone has symptoms within the first 30 days of starting a statin, whether it's muscle pain or memory changes, we would stop it. It seems like more of these reports were happening with lipophilic statins. These are ones that can more easily get through a blood-brain barrier or other tissues and stay for longer periods of time. The hydrophilic statins, ones that like water and get along with water transport in the body better, they may be recommended because fewer of those had these reported memory changes. So this would be pravastatin or rosuvastatin as far as hydrophilic. Then again, systematic reviews looking at some randomized controlled trials and some observational studies. Again, no data to suggest that statins harm cognition in those that are cognitively normal to start with. So, and even in those with some early dementia. Let me back up to that. There we go. What about diabetes? So I'll move on to diabetes, and as our third and final risk disease, the risk of dementia is increased with midlife diabetes, 1.5 to 2-fold increased relative risk. The risk seems to be greatest if the duration of diabetes is longer, therefore that midlife diabetes and carrying on for many years with diabetes. And the risk is greater if the control of diabetes is worse. There's new data looking at late life diabetes onset. That may still be a risk factor, but the studies are mixed. So for the point of this particular discussion and reviewing the latest on the midlife risk factors, we'll focus there. Both vascular and Alzheimer's disease tend to be increased in folks with diabetes, more vascular dementia risk, but definitely Alzheimer's type is also risk. The mechanism, guess what? It's complex. There definitely are strong vascular risks, right? Diabetes and stroke are associated, and that seems to be part of a risk for brain health. One study also looked at glucose levels and hippocampal atrophy. So kind of that memory new learning center of the brain of the hippocampus seems to be shrunken more in people who have elevated blood glucose levels. Looking at brain insulin, which helps to control the level of glucose in our bodies, and Alzheimer's disease, there have been many, many theories over the last 10 years, even longer, talking about insulin resistance, even in the brain, leads to greater amyloid beta toxicity, tau hyperphosphorylation, and oxidative stress, and also neuroinflammation. So these are mechanisms that may increase the risk of Alzheimer's disease with hyperlipidemia or insulin resistance within the brain. So the mechanisms, again, are fairly complex, but definitely present. Many studies going on. Does treating diabetes help prevent dementia then? So there have been a number of studies looking at very intense control of diabetes, and it really wasn't better than standard control, trying to reach the standardized targets with our hemoglobin A1C, our standardized glucose targets. Stricter control didn't help. In fact, low blood glucose episodes, so if the person trying to control glucose very strictly started having lots of hypoglycemic episodes, that actually could be worse for cognitive function. There are some observational studies coming out now looking at the new diabetes medicines, right? All the ones you see commercials for on TV. So all our SGLT2 inhibitors, our GLP-1 receptor agonists, and our DDP4 inhibitors, and metformin, which has been around a while as an oral agent for diabetes, they were all associated with reduced dementia risk. Again, this is preliminary data, but it looks favorable. The sulfonylurea, which are older oral medicines for diabetes, may be associated with a slightly increased risk of dementia. Some theory that that could be related to more hypoglycemia related to the sulfonylurea treatments, but again, still in study. We still use all of these medicines. There was a small pilot study looking at intranasal insulin along with strict dietary changes that may have shown some improved cognition in persons already demonstrating some cognitive deficits. But again, that's preliminary, but definitely interesting and looking for more information to come out on that. So just by way of conclusion, to wrap up, I know I went over a ton of information, but summarizing, these hyperlipidemia, hypertension, diabetes are common. And when we have more of these syndromes in midlife, it tends to increase the risk. Studies on whether the treatment of these conditions will actually reduce the risk of cognitive decline are really difficult to perform, and the results vary, although the strongest evidence probably exists for treating hypertension. And preventing the development of these conditions where possible is optimal, right? So if we can prevent them, great. If we develop them, then definitely monitoring early treatment is supported, but can't definitively say that it's going to prevent dementia with that. So I think my next slide is just references. So I will try to stop the screen sharing so that we can chat if any questions. Dr. Desai can answer them.
Thank you so much. I'm just going to go ahead and stop our recording.